Good afternoon, everyone. We're just going to give it a few seconds for everyone to continue coming in from the lobby. Excellent. So welcome back, everyone. Good afternoon. I am Jennifer D'Angelo from the New Jersey chapter. Just want to take a few minutes to thank you so much for attending our virtual conference for the past 2 days. This has been truly an amazing opportunity and really great to connect with everyone virtually in lieu of our in-person. Behind the scenes of me is the Hard Rock, so we're there in spirit, but glad we're able to connect virtually today. We've heard some really great presentations both yesterday and today, and it's my absolute pleasure to introduce today's closing panel, which is the technology disruptors discussion. But before we get started, just some housekeeping announcements. First and foremost, I want to thank New Jersey, Delaware Valley chapter sponsors. Without you, we would not be able to offer such a fantastic virtual education like this. So kudos and thank you for all working with us and being flexible enough to continue to host with your booths in the virtual expo. So that was fantastic. Second, as a reminder, during the webinar, please type your questions on the Q&A button at the bottom of your screen. And if there is time at the end of the session, we will be addressing all of those questions from our presentation. Thirdly, which is super important, please stay on for the duration of the presentation. You won't want to miss this. And at the end of our panel discussion today, there'll be a $200 gift card that will be presented to the winner at the time of the end of the session. So we are excited about that too. We really hope you enjoyed the past 2 days and have learned a lot and met some new folks and networking opportunities. So now I would love to turn it over to Beth Mansfield with Medmatica to introduce our closing panel.
Thank you, Jennifer. Appreciate it. And I want to thank all the committee members for the New Jersey and Delaware Valley HIMSS for giving Medmatica the opportunity to participate in this event today. I will be introducing the Technology Disruptors panel in just a short minute. I wanted to talk a little bit about our company. Medmatica Consulting Associates is nearing 20 years of providing healthcare providers with an array of services. We are committed to helping our clients realize their vision. We do this by providing high quality, leading edge solutions to organizations that seek customized services or superior value and excellent results. Our service offerings are each led by an industry expert who is ultimately responsible for service delivery excellence. We are small enough to provide individualized management oversight of every engagement and large enough to handle complex needs. If you're looking for clinical process transformation, project management, an implementation partner, staff augmentation, interim leadership, or revenue cycle assistance, please visit our website or give us a call. It is my pleasure to introduce today's closing panelists. The moderator of this afternoon's event is John Ulett. John is a senior solutions architect at New Jersey Innovation Institute. He has been delivering innovative solutions to problems in healthcare for over 20 years. Mr. Ulett has pivoted from the role of Hospital Chief Information Officer to focus directly on interoperability, the most important challenge facing all of healthcare today. Utilizing both his healthcare knowledge and his breadth of business and technical knowledge, he is leading a team of experts in delivering the right data in the right places at the right time. Our technology disruptor panelists are Andy Cohen, MD, Medical Director, Virtua Health, Kat Collard, CNIO, Christiana Care, Kimberly Buress, AVP and CNIO, Children's Hospital of Philadelphia. Thank you for your time, and John, it's all yours.
Oh boy, thank you, Beth, so much. Absolutely. It's a pleasure to be here this afternoon and sort of wrap this up talking about disruptors and technology. It's interesting because in the past, when we thought about technology and disrupting, we thought more from the perspective of IT and physicians and I think that one of the things I find exciting today is we're going to talk about disruptions from predominantly the perspective of nursing. That's where the bulk of the work gets done, the largest number of staff, the largest expenses in an organization's in nursing. And so it's going to be fun to chat with two CNIOs about how we can make a difference there. And so we're ready to get rolling here. I've got some questions and we're just going to free form as well. We'll start with Kat, which is up. No, you got to point the opposite direction, up that way. And Kat, when you think about what needs to be disrupted, from my perspective, my very first thought is, documentation comes screaming is the thing that needs the most disruption. So can you talk a little bit about the burden that documentation is placing on nursing, and then we'll talk some about how we could disrupt that.
Sure. Documentation in nursing is huge. When you make this motion around your head, that's what I think about when you think about all the pieces of or data points that nurses have to document. It's not minimal. We can see that our nurses can be documenting almost an hour or more per patient per shift. It's a lot of time. So I think the question in cutting to the chase and looking at being disruptor is really looking at what is it that nurses need to document for patient care, not necessarily following the trend and the habits of what we've been doing forever and a day, especially on paper, all those data points. What really is needed, for the physicians to see, what is needed for our ancillary colleagues to see, what do we need to document for legal purposes or quality purposes. But just because we have the ability to document every single piece of data doesn't mean we should. So where does that really sit, right? Right now we're actually working on a project to try to define that. I know our vendor has worked very hard to try to define that. But I think we need it as an industry to start working on that and be really serious about it. It's very easy to document put fields in a system, whether it's Epic or Cerner or Meditech, doesn't matter. But really the question is, should you? And do you really need to do that?
So it's so much that we need a new technology. We need to disrupt the way we're using the current technology.
Right, correct.
Yeah, and there's an interesting article came out of Nursing Informatics in June, talking about the 6 domains of burden.
Yeah, so it's actually a position paper from the American Nurses Informatics Association, and it was written by many of the key informatics people in the industry, and some of them were leaders in their vendor companies. And one of the points that they bring out, and I think it's important to talk about, is that when we are transitioning into from paper to electronics, a lot of people kind of looked at it because it's very hard to see in the initial. I've been at this since the year 2000, so it's very hard to conceptualize in the beginning. You have paper and then moving it to an electronic format. You really don't want to automate forms. You really need to automate workflows, and you really need to define those workflows. So automating paper forms is not something that I advocate for at all.
I would have to agree with you.
Yes, go ahead.
I would say one of the things that we have learned in our journey to from paper to an electronic medical record in the past 10 plus years is that, one of the early approaches we took was taking our existing paper and putting it into the EHR. And what we've learned and what we've spent many years remediating is workflow processes. That just because it was on paper does not mean it translates to the way we think, the way we provide care, and the way we document in an electronic medical record. We're very used to opening up 6-page spreadsheets and laying them across a desk and everybody being able to see all the data in one view. That is not how an EHR works, and that's not how we deliver care in an electronic world. And so really having to take a step back and bring in your human factors folks as you start to develop these workflows in an EHR and really think through not only what are we documenting, but where and how are we documenting? Where's the computer in the room relative to how you're documenting and being able to document in the way in which you provide care? And that means the structure of the documentation looks very different in an EHR than on paper.
And how do you end up disrupting the nursing staff? Because part of it is what, as you said, what we've done to ourselves. I've had conversations with nurses in my last hospital. It's like, we don't have to do that. And no, that's how I actually prove that's the care I've given, was sufficient and accurate. So is there some internal mental disruption that needs to take place with the nursing staff?
Well, I think that,
yeah.
I mean, Kimberly, I don't know if you have, if you want to go, but.
No, go ahead. I can step in.
I think that you really need to start at the top and make sure you have the backing of your nursing administration for, I'm not saying that you need a policy, but let's just say a policy, a process, guiding principles on how you're going to move forward with documentation. I also think it's very important to reach out to your colleagues as well to make sure that we're covering things. We don't work in a vacuum, and I don't ever want to portray that we do. So we need to make sure that we're documenting in a timely fashion things that they need as well. But I think you have to start at the top so that you have the backing, and then it's a matter of convincing the nurses that what you're trying to show them is that you can have 500 fields in a system where you're supposed to document. You don't need to document on every single field just because it's there. What is the care that you're giving? I look at those fields as opportunities, because in a paper world, if you didn't have the field, you might write on the margin, or you might have done something like that. You can't do that in an EMR. So we provide a lot of fields that maybe need to be hidden. Maybe some of them don't need to be there at all. Others you don't need to document just because they're there. What is the care that you gave the patient?
I want to turn to Andy. One of the things that the EMR has caused is it's disrupted medicine. It hasn't always enhanced medicine, and the whole idea that now you're focused on the EMR and interacting with it, and you've lost something. There's something lost when you're spending your time focused in the computer.
Yeah.
And how's that actually been a negative disruptor?
Absolutely. Yeah. First of all, thank you for inviting me for the panel. I really appreciate the opportunity. But yeah, I just want to echo everything that was said so far. I completely agree with my focus is really as a primary care doc, more on the outpatient side. The EMRs out there now, we work off of an Epic-based shop. There are so many bells and whistles and neat little things that the EMR can do that I do feel like as physicians, we get pulled into that, and we can get really lost in that. As a family doc and as medical director for our clinically integrated networks, my job is to really make sure that our primary care docs are forming those lasting relationships with our patients and kind of helping to create that loyalty to our system and to the docs within the system. And so how do we balance that, the gadgetry and the coolness, for lack of a better word, of what the EMR can provide with the elbow pain that our patients here for, and needing to talk to them about their mom who's been struggling with anxiety related to COVID, and their father who's fallen and needs to see an orthopedic doc and is scared to go in to have their surgery, because there's all these kind of different things. Medicine is anything but straightforward now. I think when I started, I've been in practice for 15 years and was kind of really coming in at the tail end of paper medicine. And it is amazing how different it is now compared to 5 years ago, let alone 15 years ago. And I think that now more than ever, our patients are relying on us to navigate them through, as family docs, as primary care docs, to navigate them through a very complex healthcare field. And we're supposed to do that through an EMR that can provide a million things more than paper ever could.
Right.
So finding that balance, and somebody used the word workflow earlier. I think I couldn't agree more. Finding that workflow is so imperative to creating that optimal care visit for our patients.
And then trying to balance the art of conversation that's been lost between peers. And I'll be interested also to find out how in an inpatient standpoint, but from your perspective, if you're spending your time in the EMR and not talking, which is where you're going, and then the valuable discussions peer-to-peer and with specialists and such. So has the EMR essentially disrupted the flow of medicine from a interpersonal standpoint? Colleagues?
I think it's very provider specific. I think incredibly provider specific. We've tried a number of different tactics. We've tried scribes so that we can maintain that eye contact with patients. We've tried documenting outside of the room. So if there's a 15-minute office visit, to really have 5 to 10 really good minutes with that patient and then spend 5 minutes documenting outside the room. Some of our providers have chosen to decrease their volume and go from 15-minute visits to 20-minute visits, but then they spend their time in the room documenting in front of the patient, literally having the patient watch what they're typing into the EMR to create that interpersonal relationship that may have been lost otherwise. I don't think that there's a right way to do it. I think that there's plenty of wrong ways to do it. And ultimately, it's really up to the clinician and up to the relationship between the clinician and the patient to kind of gauge what makes sense for those 10, 15, 20 minutes of valuable time.
So Kimberly and Kat, how when you're a floor nurse and you're rotating through patients, how's the interpersonal relationship built with the patient carried on from nurse to nurse to the next shift? Because you take the 45 seconds or a minute to actually connect and find out about their mom or what they're hoping to do. How's that get carried forward through the EMR to make it, to sort of continue the conversation through the whole process? Is there a place that's done? Is there an opportunity for that? What do you think?
I think there is. So the way that we are set up, every patient room has a computer at the bedside. There's also a computer outside of the room as well, so that if you needed to have some quiet, private documentation time, you could do that. But we've also created some handoff tools within our EHR, and we too are in the shop. So we've created handoff tools within the EHR, and Epic provides sticky notes for some other quick documentation and handoff that needs to happen. But even within EHR, there still is the traditional, and when I say traditional, I'm talking old school nurse to nurse communication handoff that happens at the beginning of every shift. There's also the review of the patient, their medications. The EHR doesn't preempt the need to have real communication between clinicians when handing off a patient. How we do that and how we document that handoff, each hospital within their EHR creates those handoff tools.
Right, I agree with that. We have the same similar to what you described.
So do you document things like the reason, the interpersonal things the nurses learn from the patient?
Absolutely.
Okay, and then that gets carried forward as well.
It does. The thing I want to circle back to, if I could for a second,
Sure.
John, is a question you asked earlier about, how do we approach the development of an EHR? And Kat talked about the executive buy-in. The other thing that we have to think about with these electronic medical records is they have been primarily designed for data entry and not data extraction. And it's one of the last things that we think about when we implement these tools is we develop all the processes for getting the information in. We have to be as diligent at creating the data visualization tools for getting the information out in a way that's quickly consumable and integrated for our clinicians to be able to understand the data, right? Because it's all data until it's collated and we can process it and create the information and decision making around it. But if we create data visualization tools that are disjointed and you have to go to 7 screens to put the clinical picture together, it's very difficult to make a clinical decision. And that's where you see a lot of the frustration from all the clinicians around how do I get the information easily when I'm used to a 7-page spreadsheet where I can read across one line and quickly get a summary.
Right.
Yeah, I know that when I want to learn something, I open a browser and I start Googling various words, and what I need to know comes back. And there's not any way in an EMR to Google and have it search down through the EMR on this patient or historically how, you know. So that the whole usability and the ability to access the data, to your point, I was thinking many times it feels like it's write-only data. You're not read-write, but it's write-only because I write all this stuff and nobody ever reads it. And I pray I don't end up.
They can't find it.
Yeah, you can't find it to read it if you wanted, and nobody's ever reading it. You know, all the care notes nurses put in, and then physicians ask a question when they walk in. Because it's too much work to try to pull that information out. So that whole clinical care team communication is really key. And I'm not sure how what you've seen that's changed the way that's working. And you usually stand up the EMR. It doesn't necessarily mean you have care teams and a way to communicate. Is that an area you think is open for better tools? What's the state of the tools from your perspective? Let's start with Kat.
Well, our system has a tool that is basically a Google type search where you could find things. I think the piece that is also a challenge is that there are so many different features and functions in a system that getting everyone to understand, know, and use them is also a big challenge. So we may have that, I'm just going to say like a search function, but I can bet you that if I went up to a floor right now and asked 10 people to use the search function, they would look at me and say, what? So I don't mean that in a bad way, but I think that the amount of change that we have too, I think we have to focus on what's really important, right? Because that can be input overload as well as the data input overload, right? So, and I totally agree with Kimberly. It's, you know, there's so much stuff in there. You know, I want to know from Dr. Cohen, what does he really want to know from me? I'm taking care of your patient. You know, what is it you need to see based on what I'm seeing? Certainly don't tell me you're not going to read my notes, because I would be very disappointed.
You'll
about
cry.
that.
Yeah.
But but
So
what about my note would you like to see? You know,
Yeah.
what do you want to see? So, and we have to point that to him. We can't, you know, he shouldn't have to search for it in 7 places.
Right, right.
You know, I actually think that there's opportunity, really a lot of opportunity in mobile, you know, for that type of thing.
Wanted to get, yep.
You know, so you have a computer in a room, or you have a computer outside a room, or you have WOWs, whatever. But you also, we're a very mobile world. I bet some of the people that are watching this right now are watching it on their phone. So, you know, and I'm all about the mobile thing, but what do we have in our mobile environment that we could actually see important pieces of the chart? Is that search function on that, right? Am I able to communicate to Dr. Cohen, or is he able to communicate directly to me about something that's going on with a patient? You know, cut all the middlemen, like him calling the unit and somebody answering the phone and then trying to find me. Right. What a waste of time. He doesn't have time for that. Right. And I don't have time to run up and down the hallway answering the phone either. So, you know, these are things that we really, really need to think of, not just embryonic mobile applications, but really ones that are going to move patient care.
Yeah, I completely agree, Kath, with what you're saying. And you know, we've used secure texting platforms to really kind of enhance the communication, because there is so much in the EMR, both from a volume perspective, in terms of the number of things to do, and then the number of things to read when you get to the right patient. That, oftentimes it's so important to convey the two lines of information to the right clinician or nurse, the right physician or nurse, I'm sorry, that there's no other way to do it other than to step back from the EMR and pick up your phone and text or call them. But what I find is happening is that we, in healthcare, period, physician, nurse, MA, we forget actually how to have a conversation with each other. I can be looking at my census list for the day, my patient list for the day, and the most important thing for me is to be able to recognize who is coming in to see me and who is sick. And when I say sick, like who's at risk, right? Like, so they're really at risk. And then to tease out, how do I get that patient who's sick, and this can be in the inpatient side or the outpatient side, to the next level of care to prevent them from getting worse? And how do I do that quickly and effectively? And if I send my note electronically to that doc who's got 150 tasks in their EMR, each one taking 2 to 3 minutes, 4 hours have gone by.
Right.
And just think about all of that time that's lost on that patient, where we could have been putting out the fire and keeping that patient safe. And we can do that really quickly through a mobile application, and the art of communication that just doesn't exist in an electronic platform. So,
and it sounds like it also needs to have some AI built into it, that it's able to sort through who is which of these are critical questions on a sick patient, and which are just, lower level follow-up. So,
right.
I don't think that we've gotten that level. And I know vendors are feeling a little angst about doing anything that's with the direct care piece, where they're going to help decide who gets seen and who doesn't get seen. It's clinical judgment. That's not software, so I don't want a piece of that action. But that's the kind of thing I hear you saying. If you've got that many things in your inbox, you need some tools to help sort through that.
yes.
And the direct call from the nurse when the patient is really sick and needs to be dealt with, is one way. Talking sort of about mobile tools, with text messages, we learned to not, they're asynchronous. They don't have to happen at the same time. But I'm overwhelmed with the number of interruptions that nurses deal with. So giving them yet another tool to be interrupted with doesn't sound like a solution. It sounds like just more noise level. What do you think?
I think I hear what you're saying, but most bedside nurses are already using a tool. It's some type of ASCOM, pager, something.
Right.
And those pre-existing tools are antiquated. Some folks and my team, some teams are still using, that T9 texting. So that if we can move into a smartphone platform and we really think about the design of applications such as Rover that interacts directly with the EHR, and we make really thoughtful, smart decisions around what types of flow sheet data we put in those applications. And we're using the data mining tools that the vendors provide us so that we can see what are the flow sheets and the pieces of documentation that nurses are using most often that would make their lives easier. Then we create value in using these tools. But if we simply put them out there just because they're the new shiny tool and haven't identified the value of them, then we defeat our own purposes, right? And the challenge is making sure that we help them understand the new tools that are out there. Kat said the exact same thing. We put the EHR out there, we optimize it depending on your vendor every 3 months to a year, and we send out tip sheets and we hope that people read it. The reality is they're using the EHRs the same way they did when they first learned it 10 years ago. And until you walk hand in hand with them and stand and say, let's help you look at the new tools that are out there, they're too busy. They don't have the time to optimize their individual workflows. And so that's one of the challenges that we face, is getting people up to speed with the technology where it is now.
And John,
Please.
just a segue off what Kimberly's saying is that alerts and things that go to nurses have to be managed. You can't just keep throwing things out there. You have to watch them. And that goes back to what Kimberly was saying before, where we have a great amount of ability to put data in, but we don't have the greatest ability to get data out. At least it's not easy. You get it out, but it's not easy, and it's not quick. So all the time, sometimes, but not all the time. But alarms and alerts have to be managed. And if they're managed well and they're really analyzed and they're looked at, and the amount of alerts can be decreased, so you're not having this massive amount of alerts. I think everybody today, like Kimberly said, everybody today is used to having conversations on a smartphone. I don't think that's an unusual thing anymore. But yes, an overburden of alarms can be very disturbing and problematic. But again, we have to be able to get that data out, see how many they're getting hit with, and whether they're actionable. Because nobody should be getting any alerts that are not actionable at this point in time. Yeah,
I know alerts came up when the joint was all hot on that a couple of years ago, and we all ran around working on that. And we have obviously solved the problem because we've moved on to talk about other things, or we're now chasing what the joint's asking us to be ready to talk about.
Well, we're still chasing it, but we haven't really gotten the output that she's describing.
Right.
So
I completely agree with you.
And is there some way is the integration to get all the alerts so they're happening in real time on the phone that the nurse is carrying the solution, or is there need to be, something else, some other solution? I mean,
there has to be integration to the phones, but it has to be developed and designed in such a way that what reaches the clinicians at the bedside is actionable alerts.
Right.
I don't need to see pulse ox search on a 2-year-old that's jumping up and down in the bed. I don't need to see that. What I need to know is if there's a real problem. And so we need a couple of things from my perspective, and I'm living this right now, so I'm feeling particularly passionate about it. Is that we need our vendors to provide us, our hemodynamic monitor vendors to provide us good, clean output data that comes from their monitors, so that when we're integrating this with third-party vendors into our mobile systems, that we can cleanly and easily map that data and decide what the filters need to be so that we can give clinicians actionable data in their hands.
Yep. It sounds like an ugly challenge, what you just described. Getting that clean data from the vendors so that you can actually use that. One of the panelists asked whether some kind of voice recognition was an area we needed to go to. Would that speed up how nurses are having to document if we could come up with a short, crisp way?
Yeah, I know Dr. Cohen is probably used to hearing about Dragon and probably can do some of his dictation of his notes. But we really haven't adequately gone down the road with nursing to see if they can use Dragon. One of the big things that we want to do is make sure that the patient is aware of the care that they're being given, their condition, plans for the future. They should be agreeing with the plans or help making the plans. These things are all things that can be done via dictation, and you don't necessarily need a Dragon microphone. There's so much dictation that can be done via smartphone with the right app. So I think that's something that I certainly like to see. I know Christiana is looking to do that in the very near future. So
Yeah,
Well,
I mean, dictation is an absolute game changer, because instead of looking down at the computer, you can sit next to the patient. You can stare them in the eye, look at them in the eye, and you can walk them through everything that you would normally type, and you watch their head nod. And then they interrupt and you turn the dictation off, and you answer the question, you turn it back on again, and you go. It is a game changer.
And it seems like in nursing, it need to be different, given the assessment forms you're filling are in seem to be quite a bit different than the physician notes. And the ability, I think if you could quickly jump to a spot, do your dictation, when you walk out of the room, you don't necessarily have to go back and open up the whole assessment form and fill out all the pieces. If you could fill some of them out as you go, and using voice would be changed. But you're right, nobody's that I'm aware of is spending a lot of time looking at nursing.
Yeah,
Voice dictation.
I think there are, and there's an EHR vendor or two that's starting to dabble in this. It requires a third party once again, but there's some limited text fields, if you will, that you can do voice dictation for some nursing documentation. Good. But it is limited at this stage of the game.
One of the attendees wanted to know what have you heard about a thin EMR, if you had any experience. I hate asking things I know nothing about and I can't Google it before I ask the question. So I know nothing. So I'll just start there. Has anybody heard about thin EMR?
I haven't, but it sounds fancy.
Yeah, it does.
Yeah. Minimalistic something, right?
Sounds interesting.
Mike, please tell us more about what that is so that we can talk further about it. Has anybody looked at the use of Alexas in the facility and that kind of a way for the patients to get education or interaction? Anything,
We, maybe about a year and a half ago, we took a deep dive into whether or not that was something that could be used in like an OR, where everybody's hands are busy and you just want to be able to call out for assistance. What we ran into is some of the security concerns around, this data being out in the cloud and what's being said and how it's being captured. And so we've backed down from that. I'm not sure. I know that there are other organizations out there using Amazon Web Services who have overcome that. We backed down and haven't really ventured back into it. I'm not sure if either one of the other panelists have really taken a look at that yet.
Same, we found the same thing.
Yeah, but we security conscious CIOs want to kill that as fast as we hear the word Alexa and the cloud said. I have evaluated a system that seems to have resolved that because it's being used in several well-known facilities, but it still makes me nervous, that we're going to put that kind of information out there. What about changes? We talked about workflows. Are there changes? Are there big workflow changes? I mean, we've been doing it, or is it the same work? We just need to slice it differently or sequence it. And then I think the whole interdisciplinary part plays into this. So, Kat, can you talk about whether we need to just make it thin workflows or we talked a little about not covering everything on every patient.
We've done some work recently automating interdisciplinary workflows, particularly around pressure injuries. We've made the wound care nurses pretty much virtual across the organization. I think we probably have about 1,200 beds across two hospitals. And the wound care nurses couldn't possibly see every one of those patients. We implemented a camera capture app. The nurses take pictures, the wound care nurses validate. We changed the way documentation was. And basically, we were able to identify present on admission much more accurately than we were before. So sort of streamlined down or distilled down that documentation and included it with the picture taking app And that gets appended into the patient's record and put in a place that a doctor could see it right away, because they also have to look at the picture and put in a diagnosis, right? So we have a pretty much end-to-end workflow that saved time, and I believe that saved about $4 million to the organization. So those are the kind of things that you have to get really creative about and think about, and use your resources very wisely, because we didn't change the number of WAC nurses we have, wound care nurses. We use the workflow, the electronic workflow, in a much more efficient manner.
A better tool to do that. Kimberly, anything you want to add in there?
I think one of the things we have to think about is the process improvement as we are redesigning workflows for an EHR, and really looking at the way we currently deliver care and document that care, and create the new processes that align more closely with care delivery and documentation. I can't say that we've done anything like Christiana has done, but we are looking at those workflow redesigns.
Dr. Cohen, go ahead.
Just real quick, I think that there's a huge opportunity to utilize these patient portals that exist with some of these EMRs to really maximize our time with the patients and minimize the number of clicks that we have to do to get through the visit. You know, there's no reason that that I need to review a patient's allergy list with them. If they reviewed it, you know, 5 minutes before they came in the office in their car, you know, and that's just one example. I think that there's so much that we can do utilizing that interoperability of the portals and patient communication to help us with workflows that we just don't do right now, because we're all getting used to what the portals can provide.
Right.
Once we get more used to it, I think there's a generation 2 out there that's really going to help us.
Yeah, the portal area could easily be disrupted with something useful, because I hate every portal from every the 4 providers I have. I've yet to find a portal I like. I don't have an Epic Me Everywhere portal, but I haven't had the pleasure yet of having an Epic physician, and maybe they found the cat's pajamas alongside the things they've done. But I think portals are an area that there's more that could be done, but also making it appealing to the patients to go in there, you know, is an area that can handle some disruption. When you get information back because your patients have been hospitalized, you know, this interoperability could be a disruptor. If you could get the right information back after a patient's been discharged or visit the ER, is that something that you get now, or is that an area that has opportunity?
Is that
I mean, you go to Epic Everywhere and see where everything that happened, but you know, both Kat and Kimberly are saying there's too much stuff there to try to digest. So
yeah, yes and yes, everything's a yes. Obviously we're an Epic-based shop, and I got a what we call an outside message today from somebody who was discharged from University of Pennsylvania for a bone marrow transplant, and he was hospitalized for a month, unfortunately. And to try to get through that amount of information would take me hours. You know, the data is there. Sometimes it comes in directly. Sometimes I have to go look for it, but it's there. The issue now is trying to kind of find the needle in the haystack, if you will. What's the 1 or 2 lines out of the entire book that I need to know to get this patient on my schedule and to address with him at that visit.
And you're now responsible from a care standpoint for the full, having read the full 30 days of data. And if you miss anything, we'll be seeing you in court. So right. Yeah, that so much fun. One of the attendees wants to know, have you had any conversations with AI vendors about clinical decision support? Is there any, are you being pitched on that? Anything that you've seen that's interesting or something you're looking into?
Kat, Kimberly, you?
Yeah. So we have looked at some decision support tools around patient deterioration and implemented a solution that looked at about 35 different independent pieces of nursing documentation as well as labs to help us identify a patient who is at risk for deterioration. And we used the tool for about a year and a half, and found that how we thought we were going to use the tool and how the tool was actually used didn't align. And so we're having to go back to the drawing board and really think about what information do we really need to get, and how do we want clinicians to act on that information. I think it is something that many hospitals are working on. We have a sepsis tool that we built ourselves to help us identify patients at risk for sepsis and being able to respond more quickly, and that's based on clinical documentation. But there isn't a one size fits all, and for us being a pediatric organization, some of the tools that are out there have been designed for the adult population and not the nuances of children whose with age changes, parameter changes happen in weeks and months, and trying to set up that system in such a way that it's applicable across the entire domain has been very challenging.
Kat, any AI?
AI tools, we have similar sepsis algorithms. We have other algorithms, but I'm all for that. We actually were, I asked the question or early on in our pressure injury journey, we use a Braden tool for a basic assessment, but really we want to use AI to see who are the patients that are developing pressure injuries and what is their profile. And we've gone to our data team to really kind of develop that, and which they have, and they're watching that. So, we can use the assessment tools that are out there in the industry, but we can also kind of change the way we're thinking and say, well, we have that assessment tool, but people still, develop pressure injuries. So what's the profile of the patient? What does that patient really look like? What are the real risk factors that we can really take action on too? That's just one example. But yes, algorithmic, coding is a good thing.
And one's where
with our analytics team. That's okay. We've been partnering with our analytics team and our medical informatics team to look at where are there opportunities for us to use our existing data and create, the AI tools around preventative maintenance. Yeah.
I think that the use of data, when I go to a website to buy something on Amazon, they know everything I clicked on, all of the things I looked at, how long I was there, what my normal pattern is. This is the kind of underlying data that if we had on nurses' documentation or physicians in their chart, we would be able to coach better, and we'd also be able to do this. And I've looked at the underlying audit data on my past hospital's EMR. It was woefully lacking. I had no way to actually tell, because you're talking about the nurses using the EMR the same way they were trained, and with the right amount of data and analytics, we could take that usability that's being baked in and actually deploy it to the nurses who need it, and not let's just train everybody on 3 things. We could segment that, and I've not seen that yet as something that's widely available.
Right.
Do you have access to that information, Kat or Kimberly? Is that brought forward?
Are you referring to something like, hey, this patient had this experience last time they were with us, whether it was inpatient or outpatient, click here for more information?
I'm thinking more that the nurses go here and they look at a lab, and then they go over here and they look here, and then when they want to document something, they go someplace else. That there may be faster ways to get things that have been done, and we don't know who's still using the wrong way or the slow way.
Right.
Sure.
Yeah, I think, depending on the vendor, our vendor has something called the nursing efficiency tool. We can drill down to the individual nurse to see where they're spending the bulk of their time. Is it in flow sheets? What flow sheet is it in? Are they documenting in care plans? Are they spending 5 minutes in care plans, or are they spending 30 seconds in care plans?
Right.
That information Epic continues to refine. And we're working with them to be able to get it to a point where we can then, for example, take a unit that is doing really well with their documentation, take a unit that's struggling, look at the comparison, and then start to drill in and who do we need to educate to help them use the tools more efficiently.
Right.
The PEP data that is for the provider efficiency is a little further along than the NEAT data, and many organizations, ours included, have created optimization programs that go out and meet with each physician. Somebody sits with them for a couple of hours, watches them document, and then based on the PEP data and their side-by-side observations, helps them recreate, if you will, a workflow that works for them, setting up all of the new efficiency tools so that they become more efficient.
Right.
It's so much easier done in an outpatient setting where you can set aside deliberate time to work with each of those providers. It's much harder to do on the inpatient setting when you've got a 12-hour shift and you're dedicated to patient care that entire 12-hour shift. And so many organizations are trying to figure out, how do you replicate that success in the outpatient world and bring it to the inpatient world?
Right. We have similar tools in Cerner, Lights on Network and Advance. For instance, in my clinical informatics team has been using them to do very similar things from what Kimberly describes. For nurses, we can drill down to see exactly what, where they're spending their time. And we also have, and I never like to make this announcement on a video that's going out on the web, because I don't like people to get
cover your ears, everybody.
Paranoid that Big Daddy or Mommy's watching. But we have the ability to watch video sessions. They don't get saved forever. They get saved for maybe a week. But we can actually, if we're kind of quizzical about the data we're looking at on a particular nurse on a floor, you can go and watch their video sessions and see how they're using the system, and then give them some tips on how to use things a little more efficiently. And Cerner has provided too in advance a tool to actually do it. What Kimberly is explaining for physicians, and our team that actually, kind of coaches the physician can actually do that, especially important on onboarding docs. We teach them initially, and we want to make sure that they're going down the right road and have what they need, right? So we do have those tools and we do use them.
So Dr. Cohen, do you think your physician panels would be interested in how you could make their life more efficient? I mean, they devote a little bit of time to that, or I'm just fine, leave me alone. No, I shouldn't have asked that, sorry. There's an opportunity for you to help speed them up, right? So
that we in Epic, our physicians, Epic offers a tool for optimization just based off of your behaviors. And if you click this one button, it'll reorganize what your dashboard looks like. And that's helpful to a degree to help you, have what tools you use first, at the forefront of your EMR. But I agree with Kimberly and Kath in what they said about optimization and the importance of it. I think that, again, the EMRs offer so many bells and whistles, but we're just trying to drive straight down the road a lot of the time. And there's a better way to utilize the EMRs. To answer your question directly, are the physicians excited about optimization and learning how to optimize? No, because it's another thing that they have to do, and they just want to get home to have dinner with their families and watch the ball game for an hour. But I think that I haven't seen too many examples of once the educators spend the time with the docs that they're disappointed. in what they learned.
Yes.
So I think it's all time well spent once they spend it, but nobody's
Yeah. Yeah, it's hard to believe that I'm going to have more pajama time because you're training me, but it's all going to go away if I sit with you. One more question, and then I've got my magic wand, which will be you can spend as much money as you want, and everybody will utilize the tool. What is the interesting thing if you could hire, bring in, purchase without anybody jumping you? Is there a disruptive tool you're thinking about? So I'll let you think a little bit about that. But in the whole COVID time, when we had the previous hump of COVID, the whole idea of telemedicine at the bedside, we think telemedicine, where you're doing home monitoring of patients, but some of that telemedicine ended up moving into the rooms. Was there anything that you saw that was a big help in doing patient care while you had COVID patients in rooms?
Being able to have a device in the room at the bedside that you could talk to the patient and they could talk back to you, and you could see them. And it was Christiana's also looking at instituting a robot that could actually go into a room and even, give patient medication, maybe not IV medication, but, PO medication in those cases. So, I think, are you asking us to answer your question?
No, I'm giving you time to think about the answer. Well, there's one last question about telemedicine at the bedside instead of telemedicine at home. It's a shift.
Yep.
Because we didn't think about telemedicine at the bedside till nobody wanted to go into the bedside or put on new PPE and waste another set to go in. So anything at Children's that you utilized?
So it's interesting. We are in the process of building a second hospital in one of our suburban counties. And one of the things that we are designing is telemedicine for that hospital, knowing that it's going to be a smaller community setting and that all of our specialists may not be on site. So we are creating a telemedicine, if you will, link between the two hospitals, so that the pediatrician at the King of Prussia site can dial in and get whatever number of specialists in the room to have a conversation and still provide the same level of quality care, and consult resources are available to them. We don't do that as well. We don't have the same need to do that in our main hospital because all of our specialists are here, but we do have those telemedicine consults with some of our affiliate hospitals.
That's great. Dr. Cohen, during COVID, do you think there was an increase in home monitoring devices being used, or I know we were just trying to all survive that first wave, and I'm praying that we're not on the cusp of a second wave. But telemedicine, for your patients, since you have mostly patients at home?
Well, I'll join you in that prayer, number one. And number two, we at Virtua really, we did utilize the COVID pandemic as our system-wide spark to accelerate remote monitoring. And I know Elliot Wilson's on the line, and Elliot's been instrumental in this as well. But what we've done with that program is to really utilize remote monitoring technology to perhaps discharge patients a half a day early, a day early, and otherwise, and then to follow up with an extensivist model by some of our clinicians that were trained in COVID to really support these patients at home. And by doing so, we were able to decrease the length of stay, perhaps decrease a readmission rate. That debt is still coming in, but certainly minimize staff exposure and physician exposure to the disease. So that's something that I've been very proud of, and we're now looking at expanding that into other options. So with regards to that, I think that that's a tool that's really going to transform the way that we approach medicine, as we're really focused on optimizing length of stay.
Yeah, we don't want to just send them home sicker without some additional support. So that's a great model because we were all trying to decant as many patients as we could safely. And you may be able to go home, but you want people to watch after you. So that's a neat program.
Yeah, I mean, everybody talks about, you know, the catchphrase I think is hospital at home. Well, hospital at home starts with something like this.
Yeah.
Right.
Yeah. Okay, so I got the magic spend and wish, whether exists today or not. You know, what would you like to see? So we'll start. Oh, I got to keep reversing directions. So, Kat, if you could spend, you know, any amount of money, is there something you'd like to try that might be technology disruptor?
I think that, you know, you talk, well, I have many things in my head, but you talked a little bit about the portal, right? And having so many. Maybe the patient should own a portal. And in that portal, you have the opportunity to be able to connect some home devices that you have, blood pressure, weight, you know, yada, yada. And those things can be plugged into our EMRs back in a healthcare setting. I think the look is we have to be realistic in thinking of how can we best take care of patients when they're home remotely.
Yeah, excellent.
That's one idea I have.
And it's doable now. And, you know, the whole idea that we all have phones with video capability, if 10 years ago, you'd say, what, you know, would you be willing, you know, what if you could talk and see your patients at home? So it'll never happen. And who would pay for it? It turns out we're all paying for it ourselves. Right. So go down to Dr. Cohen and end up with Kimberly. So I'll give you just a moment longer. All the money in the world, and it'll be adopted and implemented. Is there something that you don't know if would work, or you're sure it would work that you'd want to spend money on?
Yeah, well, I love the portal answer. That's near and dear to my heart. But short of there being one universal EMR across the entire country, which I think would solve a lot of problems. Mm-hmm. I saw something once at a Pop Health conference that blew me away, and I would love if it went into effect. And that was essentially a credit card. And every patient would carry this credit card with them. And whenever they had any interaction with healthcare, they would insert their credit card into the computer, and everything relevant to the doc would go on the credit card. They take that credit card with them from place to place. They put it in your EMR, and every vaccine that they got at a different CVS, or every emergency room stay at the hospital next door or whatever, got uploaded into your EMR. I think anything that we can do to make electronic interoperability more seamless and effective is a win for us as docs and clinicians and patients as well. So
that's great. Kimberly, all the money, what are you going to spend it on?
I think I'm going to spend it on a personalized, integrated, and dynamic EHR experience, to the point that as I log into the EHR, the way I think, the way I process the information I consume is displayed in the way that I need it. And that, to your point earlier, John, the system also says, you normally look at this. Did you want to look at this today? Just like you go onto a Google search or you go onto Amazon, and then suddenly when you go onto Facebook, all the ads pop up. I'd like to see that similar type of interaction in the EHR from the clinician perspective, so that it makes data consumption and logging and trudging through the EHR that much easier, with AI helping you to think through things such as, you just ordered Tylenol. Did you remember that this patient is also on NyQuil and already has Tylenol? Just those things that, and not as BPAs that pop up that people blow past, but it's just little bubbles that show up to help you see this information, make concrete decisions, and move forward.
You know, the idea of softer software where it's molding itself to the way you work, because, you know, you're still going to work that same way, whether it changes itself or not. So all the stuff that's on the screen that you never look at, touch, you've never in your life entered anything is just visual distraction. You know,
Right.
it's cognitive load in you trying to get past all of that. So
Mhm.
if that's a cool idea if it could actually refocus itself. So I'm pretty much wrapped up with questions. I've been following along with the Q&A, and they've asked some really cool stuff. Thank you to everybody who submitted Q&A things. I didn't get to all of them. There were the ones that ex-CIO could understand to ask. So the ones that I didn't get probably was my failure there. Any last comments from the three of you? And then I'm trying to spin up Chaz and company so that they can go ahead and come in and finish up moments early. But we'll start. Kat, any I don't know.
Thank you everybody for joining today. I think this is Kimberly, Dr. Collins, is a great conversation, and thank you, John, for leading us. I think that's a good conversation, and don't ever give up your vision, whatever it is you have out there.
Kimberly.
I too wanted to say thank you. This was a fabulous conversation. I appreciate your facilitation. It was great to work with Kat and Dr. Cohen. Thank you for everyone who dialed in to hear us speak. We really appreciate your engagement. And we thank you for continuing to be on the front lines and supporting your organizations and caring for patients and families.
Dr. Cohen.
Again, I just want to echo the comments from everybody and thank you, John, for hosting. And I just want to let all the participants know that I think it's really easy for us to get caught up in the technology and the advancements in what EHR technology can provide. But at the end of the day, healthcare is about doing the right thing for the patient, and it's about supporting the healthcare providers along the way at all levels. And from a disruption perspective, if we can disrupt, keep the patient in mind and keep the providers in mind, you've got something that's a winning ticket there. So I just want to thank everybody for their time, and that's about it.
Yeah, thanks to the three of you. I think one of the things that I got out of this is sad for me, who loves to buy shiny toys. Just ask my wife about all the technology that's sitting on the shelf, or I've already taken to recycling. No, don't ask her about that part. But I think of disrupting technology. You know, we need a thing, a device, something, and really what we need is to disrupt the way we're doing things, disrupt the use of our current technology as opposed to adding new technology. So I think that was an interesting point. Chaz, are you going to join us? I'm trying to see who's coming in. Somebody wants to give things away. There he is, back.
There they are.
I'm here.
Ooh, look at that. Hey, guys.
I'm here. How you doing?
How you doing?
I don't know where Elliot's at though.
What are you talking about? Chaz, I'm right here. I'm in the restaurant. I told you I was going to meet you at the restaurant at the Hard Rock. Where are you?
I'm still at the session.
What?
No, no. How about the lobby bar?
The lobby. You want me to meet you down at the lobby bar? Oh, all right. Give me just. All right. Hold on a second. I got to travel all the way over
before
there.
the exhibitor hall opens up. So
this isn't it. Wait, is it?
No,
that's definitely not it. Not it.
I'm
Not
here.
it. Sorry. Hard to get over there. Trying to find out. Nope.
No.
No, definitely not. Definitely not. Okay.
Oh.
Yeah, hey, there you are, buddy.
Oh, here we are. All right. Thanks. Cool.
Whew. Sorry about that. Well, what a great conference, right, Chaz?
Man, what a great conference.
So good. So many people attending all those sessions. I mean, you have really got to hand it to
400 people registered, Elliot.
I know, it's amazing. The HIMSS planning committee just did an excellent job. Those chapters,
they did. I'll tell you though, the food was just okay. It's been better in years past, but hopefully next year we'll put in a good word and we'll get some better food, right?
Yeah, for sure.
I really enjoyed the sessions though. My goodness, speakers were amazing. Always Russ Brinzel, he always comes through with some great presentations and some stories,
Oh, absolutely. And Cletus's presentation yesterday afternoon about diversity in healthcare IT, so good. I mean, those conversations can be really hard to have, but they're so necessary to have. Really important.
Absolutely. And Cletus Earl, my goodness. Oh, my, what a powerful presenter. And he looked good in a tie after all that time.
That was a nice suit.
How about early on the other day, Sean Slavinsky, coming through with, his presentation about consumerism. Oh my goodness, it's amazing.
Yeah. Hey, did you get a chance to stop by the sponsor hall? Our chapters are like, we're really fortunate to have like those kind of sponsors there. And it was great to kind of go in and see them all virtually. Did you get there?
Yeah, I did get a chance. It was always a great chance to stop by, check out all their information, right? I was overwhelmed with the amount of the sponsors and had their virtual booths open, and we got a chance to talk and fill out. Maybe I'll win a few things too, right?
All right. Just hoping. I like those earbuds. Connection was given out. Hey, were you even able to see all the sessions though? I mean, there was so much content.
There was so much content. I know everybody's so busy, and I really didn't get a chance to see all of it, but I got to see most of it. I wonder, there's going to be recorded, and posted.
Oh, come on. Of course they are. I mean, everything's going to be posted at the event website at https://dvnjhimsevent.com.
Oh, awesome. Well, yeah, everybody have to go there and check that out. I know I will catch up on all the things I missed. Oh, wait a minute. I'm getting a text.
Oh,
the winner from our last session. Can you?
Oh, awesome. Who was it?
Can you believe this? It's Brandy Reeves from Virtual Health.
Oh, that's great. Good for her. Congratulations.
And this was not fixed at all. Not because you and I are both from Virtual Health.
I know, right? Virtual representatives.
We did not pick this. So anybody that thinks it's fixed, it was DeMars.
That's so great. Hey, so what do you think? You think we should go lose some money in the casino? Huh?
Yeah, well, I'll tell you what, we'll grab another drink and maybe we'll head back to see the sponsors in the exhibit hall, and maybe we'll meet some of the other folks from just coming out of the panel there. And I think that, I think they're open until like 6:30. So make sure we get back there and see them all.
Yeah, good point. Cheers, Chaz.
Cheers. Have a great one. Thank you, everybody.
Thanks, everybody.